Welcome to this webinar, Learn at Work, which is sponsored by the journal Work, a journal of prevention, assessment, and rehabilitation. I'm Karen Jacobs, the founding editor of the journal, and I'll be the moderator today. I am so delighted that we have two speakers who are going to discuss their article that was published in Work titled The Importance of Health Management and Maintenance Occupations While Homeless, a case study. So I'm now going to turn it over to our two presenters.
Wonderful. Thank you so much, Dr. Karen Jacobs. So we will go ahead and get started. I want to take a second to introduce ourselves to you. So my name is Tyminski, and I am an instructor in the program in occupational therapy at Washington University School of Medicine in St. Louis, Missouri. A little bit about me. I am a community-based mental health practitioner by trade. Ever since I graduated from OT school back in 2012, I have worked in the community. It has sort of been my first love. My first job was at an organization here in St. Louis that works with individuals who are experiencing serious mental illness, substance use, and who have a history of homelessness. They weren't actively homeless when we were working with them, but that organization does happen to be part owners in a homeless shelter. So during my time, I got interested into the shelter and had a chance to visit over there. And when I walked into the shelter, I took a look around and really thought, wow, this is an extreme state of occupational deprivation. And that was sort of where my love of OT and the homeless population was born. And I got the chance to make that my doctoral project for my post-professional degree. And from there, we were able to put OT services in our local homeless shelter through fieldwork students. And when some politics came up and the shelter changed hands, the shelter, one of the shelter organizations said to us, OT has been the most beneficial service we have ever put in this shelter. Would you come with us to our main building and provide OT? And so that is how we now have a pro bono OT clinic in an organization here in St. Louis called St. Patrick Center, which is the largest organization in St. Louis serving individuals who are experiencing homelessness. So that is just a little bit about my background and how I work with this population. And now I will let Dr. Ariana Gonzalez introduce herself.
Yeah, thank you. Yeah, so again, my name is Ariana Gonzalez. I actually privilege of being Quinn's mentee when I went back and got my post-professional doctorate at WashU. So I did my project with her in this population, but I also helped her supervise the students that came through that student experiential learning clinic. So that's my experience with this population. And currently I am working with individuals transitioning into the community post-incarceration. So that's a little bit about me. I think we can go ahead and get right into the background. Yeah, and so according to HUD, over 500,000 people are experiencing homelessness on any given night. So we wanted to start off with some background, and also I wanted to explain people or persons experiencing homelessness, otherwise known as PEH. You'll see that throughout the slides. So life expectancy for this population is over 2 decades lower than the general population. The life expectancy for PEH is anywhere between 42 and 52 years, while the average life expectancy in the US is 78 years. In fact, middle-aged adults experience such debilitating health and functional issues due to homelessness that their bodies often resemble that of the geriatric population. They're also 3 to 6 more times likely to get sick as compared to the general population, 5 times more likely to be hospitalized. 70% are without health insurance, and this does lead to higher use of the ER, and they're 8 times more likely to use the ER than the general population. They also experience a variety of chronic conditions that you see here on the slide. So these are some of the very common ones for the population, including cardiac disease, lung disease, and diabetes. There are also a wide range of skin and exposure-related conditions that people experiencing homelessness seek medical care for, such as frostbite, tuberculosis, and STIs. And we know that chronic conditions, such as the ones that you see here on the slide, it's especially important that individuals are able to follow through with medical advice, take necessary prescriptions, and implement the recommended lifestyle changes to prevent further exacerbation. However, with this population, there are a lot of barriers to doing so. So this is a little glimpse into the daily lives of people experiencing homelessness. There was a study done that captured all of the different occupations that they engage in on a daily basis, and these are two of the main ones. So occupations of survival include all the activities one does during the day in order to survive, like finding food, shelter, clothing, and a place to sleep. And then the other main category was occupations of self-management. That's trying to find out where you're going to wash your clothes, where you're going to manage your medications, and how, and where you're going to shower, those kinds of things. So instead of opportunities to engage in the general, typical adult population occupations like starting families, becoming established in your career, developing relationships, and leisure pursuits. This is kind of what people experiencing homelessness, this is what they're doing on a daily basis. So due to the tremendous amount of effort and time that this population puts into these occupations right here, it leaves them with very little time and energy to meet health needs and to kind of deal with that. So as I kind of alluded to, there's a big issue with competing priorities. There are a lot of other things that this population has to do on a daily basis that leaves little time and energy left over. One study shows that 73% of people experiencing homelessness reported at least one unmet health need due to various factors related to inaccessibility and competing priorities. Some of these health needs that they were unable to meet were inability to obtain prescriptions, inability to receive mental health care, inability to get necessary medical or surgical care, to get eyeglasses and dental care. And even when they do receive care, they're often discharged with recommendations that are difficult to follow under their circumstances and their living conditions. And this inability to manage these conditions properly is part of what leads to that vicious cycle of health disparities that we see in this population. And finally, there are medication adherence barriers with this population. Some of the common ones are access to medications, forgetfulness when taking medications, the side effects of medication, and the lack of perceived benefits. So this was just some of the background, some of the medical background and health disparities that we see with this population. And I'm going to hand it back over to Quinn, and she's going to go into a case study where you'll see a lot of these, plus even more barriers that this person experienced.
Great, thank you so much, Ariana. So, I mean, having worked in this population for so long, I have really seen a lot of these things firsthand. And before I get to my case study here, I want to just talk about some of the issues that Ariana mentioned during the background. So things like inability to get eyeglasses. We actually, in our clinic, we are within this larger organization who gets a lot of donations, and they will actually give us all of the reader glasses, just the ones that you pick up at the store, that they get donated, and we keep them in a box in the clinic for when we do groups and other individual interventions, and they are always empty. Like they are a hot commodity because almost all of our clients have issues with their vision, whether that's due to diabetic retinopathy or just like other concerns with low vision. We really see extreme visual deficits in this population, and it's not really something that they have access to regular care around. Anything that's specialized really becomes an issue, as well as mental health care and the sort of the maintenance around that. Anything where there's a chronic condition that requires health promotion and it requires an individual to take medications regularly. It is not out of the ordinary for a client to be prescribed a medication, and then when I follow up with that client in a week and say, hey, how's that med going? Them to say, it got stolen, it got taken from me when I went into the shelter staff said I couldn't have it in there because it was a controlled substance, or whatever that may be. So really sort of maintaining those health promotion angles are really very dependent on their environment and their context. Very often those things inhibit their ability to actually engage, even if they want to. Not to mention refilling a prescription can very often be a whole day, or even attending another doctor's appointment can be a whole day. We here in St. Louis have a large hospital system in our downtown area that most of our clients seek their emergency services at. And of course, that hospital has satellite sites out in our suburban areas. And very often they will make the clients follow-up appointments at the satellite sites in the suburban areas, which are easily a 2-hour bus ride away. We don't have a great public transportation system here in St. Louis. And so very often my clients will not be able to attend those follow-up appointments because they can't be away from the shelter that long. They can't miss work for that long. They simply don't have a bus pass to get there. So, I mean, we're really seeing a lot of barriers to regular healthcare. And what I have recognized in the time that I've been doing this work is that our healthcare system does not understand that. Despite, a lot of the education we get, we still sort of have this idea that it's an intrinsic factor, that this person is doing something wrong. It makes me cringe every time I see the word unmotivated. And I call it the myth of the unmotivated client, because I believe that these clients are not unmotivated. There are barriers in their way. And so I do a lot of education with physicians. And they'll say to me like, well, I've put everything, I've sent transportation for this client and I made an appointment at the local clinic for them. Why didn't they show up? And sometimes thinking as much as like, if you haven't seen a doctor in 20 years, could you imagine the fear of what that appointment is going to look like? And so those are the kind of things that we're up against. And I want you to sort of be thinking through as we go through this case here. So this is the case of Blake, and his name has been changed to protect this client's identity. So Blake was a 36-year-old Caucasian male. We made contact with Blake at the local homeless shelter here in St. Louis. And this was when we were providing OT services actually at the shelter. And he was referred to OT through the staff at the shelter. The staff approached us and said, quote, he really is a problem here. He keeps wetting the bed at night, and we just can't continue to allow him to have a bed here if he's such a mess, unquote. So first of all, that sort of referral threw me a little bit. The fact that this individual was clearly, having some medical concerns that were causing this adult to wet the bed, and that would result in this person losing their nighttime situation. A little bit about Blake. So Blake had a history of 20 years of homelessness. So had been homeless since he was about 16 years old, in a variety of different situations. So couch surfing, meaning sleeping on other people's couches. We also call that doubling up sometimes. Encampments, and those are what we see as like tent cities. You will often see them in busy cities, under overpasses, excuse me. But anytime that sort of a little town pops up of individuals experiencing homelessness. And he had been housed previously, but had not had successful experiences of housing. He did have a history of incarceration for drug charges. And he did have a history of substance use and substance distribution, which led to his history of incarceration. So one of the things that we run into when we work in the homeless population is that very often we do not get good data on our clients. It is very difficult to get any documentation on these clients, and thus the majority of the information that we are receiving is self-report. Even now that our clinic has moved into this larger organization, we actually have hired a full-time OT to sort of liaise with the clinic. There is still very scant documentation in the systems that are used to track the homeless population, and very little of that is medical data. You might get some social data, but very, very little of it is medical. And one of the big issues that we run into with these clients is that they very often don't have diagnoses of conditions because they've only ever been seen in emergency rooms. And so there's no documented diagnosis that they could use to obtain services. So a lot of times we have to go about actually getting them that diagnosis. So a little bit about Blake. So the major issue that we saw immediately with him was that he had obesity that impacted his ability to complete occupations. Blake was classified as morbidly obese. He also had chronic obstructive pulmonary disease, type 2 diabetes, and prostate concerns, which were causing his urinary incontinence. He would very often complain of prostate pain. Blake did also comment about unspecified psychiatric symptoms. He reported that he knew he had some mental health diagnoses, but he didn't know what they were, and he didn't take meds for them. But he did report smoking cigarettes and drinking alcohol as coping mechanisms. As I mentioned, he was unable to secure any governmental assistance due to that lack of diagnosis and inconsistent hospital records. So because there was no formal diagnosis, he'd never seen a psychiatrist who had given him a diagnosis, or there was no IEP when he was younger, we couldn't use that diagnosis to qualify him for any Social Security supplemental payments or anything like that. He did demonstrate depressed mood, bouts of explosive anger, and a decreased sense of self that was really visible through his self-deprecating humor. He was a very humorous client, but a lot of it was at his own expense. And it also became very evident that he was a target of bullying. So both the staff at the shelter and the other shelter residents really bullied him a lot for his increased food consumption and his poor hygiene, often related to his urinary incontinence. Because he did have urinary incontinence, he very often smelled like urine. And he often, because he was overweight, it was very difficult for him to complete his ADLs, to care for himself, to change his clothes, and he didn't have a lot of clothes that fit. So if he soiled himself, he had to wear those clothes. But he did not use any recreational drugs because he was on parole, and he would always tell us that he would not smoke marijuana or use any recreational drugs until he was off parole, just cigarettes and alcohol. So we did the Canadian Occupational Performance Measure with Blake when we first worked with him, and these were the goals that he came up with. So the first was health management. As I mentioned, he had a lot of concerns about his urinary incontinence, about his prostate, about his health. He was concerned about his weight and his ability to walk. He reported a lot of aches and pains in his joints, and his back hurt a lot. So this was an area he really wanted to address. He also wanted to seek housing. This is not out of the ordinary. The majority of our clients put housing as a goal. I do, when I work with clients in this population, always say, like, I can't get you housing. I don't have the ability to, get you those funds, but I can do everything else. We can work together to make sure that you have all the skills necessary to move into that housing. And so that is really what we worked on. And then finally, increased social engagement. He was really interested in having some friends, and he was actually even interested in having an intimate partner at some point. So based on that information, we went ahead and began our services. Blake was extremely excited to participate. He, like I said, he was a very humorous client, and he always got excited when we were there, even though it was generally mocking, like, oh, you guys again, but we knew he was excited that we were there. He participated in both our individual and our group intervention sessions. So we ran group twice a week, and then we usually saw him at least one more time a week for an individual session. So our group sessions were really designed to address skills that we had identified either through literature search or just through like functional observation that all individuals living in this setting had issues with. Things like home management, medication management, community resources, and community mobility. So we focused a lot on, like, when you move into that apartment, how are we going to care for it? How are we going to pay our bills? Do we understand how to manage our medications? Do we know how to get around our community? And what if we move to a different area in town? Will we know how to get around then? Individual sessions for him, we really focused on that health management and maintenance part. So nutrition and exercise, and then advocacy within the healthcare system. Blake was a really great example of someone who experienced a lot of stigma in healthcare, where the healthcare industry really ignored a lot of his pains, a lot of his concerns, partially due to his weight, but then partially due to his homeless status. Very often he would go to the ER, get discharged within a few hours, despite it being a serious issue, because people would see him as a frequent flyer and discharge him. So that was really where we focused the bulk of our work with him. So an example intervention that we did to work on health promotion. So his goal, he reported that he would like to lose some weight. But he had a lot of concerns about this. So if we are thinking about our trans theoretical model, our stages of change, I would say he was very contemplative about this. He very much saw a need to change, but had some reservations about doing it. So despite the fact that he wanted to make that change, he wasn't really at a preparation or action phase yet. And so we needed to sort of develop that insight with him. We needed to show him where he was and where he needed to go. And so he even voiced that he was very concerned that if we started working on losing weight, that we would starve him. And that was, you know, a valid concern of his. So we wanted to assuage that. So we started by just asking him to track. We just started a food diary and we asked him to track the amount of food eaten. We did not make him change it at all. We simply said, all we want you to do is be able to write down what you ate. And he did this, so he complied with this, and he was truthful, and so much so that like one day for breakfast, he reported eating 35 yogurt cups for breakfast. And that is a truthful reporting for him. And then, so once we started getting him to be able to just recognize how much he was eating, we also wanted to implement exercise as part of our weekly OT sessions. So I will note that one of our goals for him was to get him in the water, in a pool, because his joints were very painful. He reported pain in his feet and his legs and his back. And he often hurt so bad he had to take multiple breaks during a 3-block walk uphill to the bus stop that he took weekly to meet with his parole officer. So our long-term goal with him was really to get him in a swimming pool to do some exercise. But there were a lot of barriers to that. 1, we had to find a pool available. 2, we had to get transportation to that pool. And 3, we had to find swim trunks to fit him, because all of the pools required that he actually wear swim trunks, not street clothes in the pool. And that was a bigger feat than you might imagine. So we started with some basic walking. As I said, once a week he had to walk to the bus stop, which was 3 blocks away. It was a slight uphill jog, but not too much, to meet with his parole officer. And if he did not make that meeting, he would be in violation of his parole. So this was mandatory every week. And so what we would do is at the end of every meeting that we had with him, we would attempt to walk to the bus stop. If we didn't make it, that was okay, but we just wanted to try. So, you know, really the idea was that we wanted to increase his ability to be functional in the community. We wanted to increase his ability to get to the bus stop, because once he got to the bus stop, the world was his oyster. He could get anywhere from there. And we wanted to, you know, obviously take the exercise with it. So we really were sort of trying to combine 2 of his goals. So some days we made it all the way to the bus stop, and some days he was too winded and he only made it part of the way. But most often it would take us about 30 minutes to walk 3 blocks. And that's okay. You know, we worked at it a little bit at a time, and we saw progress. After 6 weeks of twice weekly OT sessions, we saw improved eating and exercise. He was able to make it to that bus stop. Though it was slow, he was able to make it there. We saw him at least consciously thinking about what he was eating. And he would tell us things like, you know, I didn't eat that 3rd plate today. You know, I thought about it and I didn't really need it. And then he also learned and demonstrated independent living skills. We saw him, you know, start to take care of his medications. We saw him start to manage the things in his life that he needed to do. We also saw him start to stand up for himself and do it appropriately. In the past, when he would experience the taunting or the bullying, he would simply respond in anger. And this explosive anger was exactly what the bullies wanted. It was very much that explosion that they got what they wanted. And so we worked through what are better ways that you can engage with them, and how can you make some friends who will stand up for you. And he was started to be able to stand up for himself and tell people when the things that they were saying to him were not okay. And during this time, he also qualified for a rapid rehousing program. And a rapid rehousing program is designed to place people experiencing homelessness in housing with supports to allow that client to eventually take over the housing payment after a period of 6 months. So they put the client in housing, and then slowly over a period of 6 months, the client is supposed to take over the payment. So they basically give them 6 months to get on their feet. So using a computer, we identified an appropriate living situation within his price range and near public transportation. And then actually myself and an OT student went with him to visit the apartment on the bus line. We took the bus with him. We walked to the bus stop. We made the transfers with him, and we completed the application. And so that was a really wonderful experience for him to sort of put all of this work together to go out and pick out his apartment. Unfortunately, what happened here is not out of the ordinary for this population. It was a crisis. And this is very common for a lot of our clients. So after we went and identified that apartment, Blake was approved for the apartment, but because systems are slow and paperwork is slow, he had to wait several weeks for that apartment to kick in. And during that time, he had an episode of cellulitis, which is a skin infection affecting his lower legs. It caused fever and swelling. And rightly so, Blake realized he was in need of medical attention, which actually was an improvement for him. He in the past would not have recognized that need for medical attention and probably would have let it go. So that was a huge step in the right direction. So he was unable to take himself to the hospital due to the pain in his leg. So he couldn't necessarily walk to the bus stop and catch the bus. So instead he called 911. The ambulance came, took him to the hospital, and he was admitted and monitored for several days to treat the infection on his legs. I will say that when they discharged him, they gave him follow-up medication. It was immediately stolen. He ended up having to go back in at one point to get that infection dealt with again because that follow-up care was not provided. But because he had been admitted to the hospital and had not been in his bed for one night, he lost his bed. So the rule was that if you missed your bed for one night, you would lose your bed, regardless of if you were in the hospital or incarcerated or any of those things. So he lost his bed, and that was very often at the purview of the staff. So they sort of made that decision based on whether they liked someone or not. They could bend those rules for clients that they felt were maybe a little bit more well liked versus ones who weren't. And as I've discussed, he was sort of bullied by the staff. And he was seen as a difficulty because he did wet the bed, and they had to put extra time and effort into him. So he was discharged from the hospital, and he became acutely homeless and forced to sleep on the streets. Our only other shelter in St. Louis is actually on the other side of the downtown area. So his only other option was to trek to the other side of the city to sleep there. But that shelter was different because that shelter is what we call an overnight only shelter, meaning it opens at 6 p.m. and it closes at 6 a.m. Where the clients have to be out of the building between 6 a.m. and 6 p.m. So that means that they spend all day long on the streets. And one thing I should note is this occurred at the dead of summer. This was like August, which in August in St. Louis is about 100 degrees and humid and miserable. And so he was stuck out on the streets in August with this infection still going on in his legs. He did decide to stay at the evening only shelter, and we briefly lost contact with him during that time because when our clients are on the streets and they don't have a cell phone, we sometimes can't follow up with them despite our best efforts. But when he did arrive at the other shelter, they did call us, and we were able to go over and work with him over there, even though that's not a shelter we have a contract with, that's not a place we work. This was a client that we really felt we wanted to work with, and they were willing over there at the shelter to allow us to help them because I think that they saw that he was going to be a lot of effort for them. So we agreed to continue to work with him. So, as I mentioned, he continued to suffer from his cellulitis, his urinary incontinence, and his prostate pain. The staff at the new shelter immediately targeted him the same way the old staff were because of his urinary incontinence. This seemed to be the big issue. His prostate pain continued to get worse to the point where very often he was missing the urinal when he was urinating, and it was going everywhere, making a very large mess. And he still was wetting the bed. So in these communal spaces, these things become problematic for not only the staff, but the other patrons in the shelter. And so a lot of what we did was first shelter staff education. One of the things that we had to do was educate on that this was not something he was doing intentionally, that this was a medical concern. And so, you know, we really had to help them understand that like this was not a behavior he could change on his own, because they had said to us if he didn't quote unquote change his behavior, he would be asked to leave the shelter. And he was very often like reprimanded for his urinary incontinence. So we educated them on the causes of incontinence, and we provided suggestions, things that we actually brought in Depends for him to wear in the evening. Again, that was very difficult because he needed a very large size of Depends, and those were difficult to find, and we didn't have funds. So everything that we were doing was done completely out of my pocket. So just trying to find these things like was costing a lot of money. Other interventions that we provided to address this issue were things like the use of a bathroom schedule. And we also provided him with wet wipes that he could use for his own personal hygiene. Like I said, one of the issues that he had was very often when he would urinate, his stream wasn't consistent. And so it would very often like dribble on himself. And so we provided him with wet wipes so he could clean himself up and so that he wouldn't have to walk around with that urine smell on him all day. And then the other thing was he was really running into issues due to the size of his stomach and his arms with like being able to aim when he urinated. And so we helped him create a low-tech assistive device that had a long handle and reached around his body, and it was sort of a funnel to catch the spray of urine and direct it towards the toilet. And one of the things to note when you're working with individuals who experience homelessness, if you are providing them assistive devices, it better fold up, because if it doesn't fit in a backpack, they're not going to take it anywhere and they're not going to be able to keep it. And so really working on how can we create something that folds up or comes apart that is easily cleanable, that he can use. And that was a really interesting adventure for both myself and my students in problem solving and creativity. So that tested all of our OT abilities. So one of the big things that we saw in Blake's case was this role of shame in homelessness. Despite these health management interventions that we provided, he continued to really struggle with poor health, hygiene, and the related embarrassment of both of those issues. So he reported to us that the embarrassment and shame of his health and his hygiene became a catalyst for him to relapse to using illicit drugs, which resulted in his eviction from the second shelter that he was staying at. And because of this, he actually ended up losing funding for that apartment that we were waiting on, resulting in him, continuing to be homeless and living out of shelters and out of the streets. So, what we saw here was sort of this systematic failure to meet his needs. We saw the hospital discharge him with an active infection and medications that he was unable to keep secure. We saw shelters that revoked beds for needing to obtain healthcare in a crisis. We saw another shelter that threatened to remove him due to his inability to deal with his current circumstances. And really, we saw the stigma of homelessness that was pervasive for this client. It questions his self-worth. He lost who he was. It was very dehumanizing. And he sort of lost his spirituality. The shame and embarrassment of his continued failures really caused that substance use for him. He got to the point where those coping skills that he was using before were no longer enough. And so despite, OT trying to provide coping skills, it wasn't mitigating what was coming at him enough. We weren't filling up his cup enough for how quickly it was draining. So I say based on all that, we learned a really valuable OT lesson here. And one of the things that I really do want to note about this case study, and one of the reasons we chose it, is because I do have a lot of successful OT case studies in homelessness that I could have put out. But there was a reason I chose this one. And because it demonstrates the potential success seen with OT, but it more strongly illuminates the difficulties experienced by this population in receiving consistent care for health-related quality of life. There were numerous times where Blake's needs were not adequately addressed. Like I said, the hospital discharged him with active infections. The shelters continued to not support his needs. And throughout this journey, Blake reported that OT was consistently the only one who listened to him and who he felt supported him. He said that we were his family throughout this. He said the OT team genuinely cared for him and were respectful of him as a person and went beyond their duties to ensure he cared for him, often purchasing supplies out of our own money. So, you know, the lesson to be learned here is that we have a system that is not properly equipped to help people deal with their ongoing needs, whether that be emotionally, spiritually, mental or physical health, or even healthcare needs. And so individuals like OT can make people feel respected and understood, even in the midst of this system. You know, you don't have to have all of the answers, but very often it's the compassion and the empathy that gives someone that sense of purpose and just feels like there's someone with them fighting this battle. You know, making systematic changes is so huge and sometimes feels so daunting, but there are things that we can do on such an individual level that can change someone's outlook, even for a moment. And so we've seen that evidence, you know, out there, and we've seen growing evidence, I would say in the last 10 years in the area of homelessness and OT, just tremendous growth in evidence. It demonstrates the effectiveness of OT in the homeless population. We know that that is true, that these OT interventions are successful in increasing employment and education prospects, money management ability, and coping skills and leisure pursuits. But I think, you know, there's more there that we have yet to investigate. And it's a lot of that is about how do we support that health promotion? How do we keep people's self-esteem up and their self-concept there when the system is continually beating them down? So I am going to let Ariana tell you a little bit about how we're going to conclude this, and then I will finish up with our future directions.
Yeah, thank you. Yeah, so as Quinn was just saying, although OT can make such a big impact on this population and their health needs, there is such a big need for better and more comprehensive and holistic care for this population that includes multiple disciplines, multiple people working with this population. And as you've seen throughout the case study and through the evidence provided in the beginning, people experiencing homelessness face daily obstacles in meeting their basic needs, including their healthcare needs. And they have not, little to no means for managing health conditions. And on top of that, the stigma and the way that they're treated by others is dehumanizing.
Great. Yeah, so really next steps, where do we go from here? As I mentioned, I think OTs have a huge role in working to decrease barriers to engagement in occupations and to reform identity and find meaning and purpose for this population. We have been doing a lot of work in the homeless population with our clinic, and we just have such a good access to this population to understand what this lived experience is like so that we can serve them better. Because until we understand what their occupations are and how their occupational performance and their participation is changed by being in the context of homelessness, we'll never be able to serve them in the correct ways. And as Ariana said, that's this team-based approach to care for this population is really important. We really had to do a lot of education of the social service providers, and they did a lot of education to us too about what it's like to work through those systems. And so the stronger we are together and the better that we can do in making sure that these clients do not fall through the cracks in our healthcare system, and ensuring that we can improve their health and well-being instead of worsening it. So that's what we have for you today. Here's our references. And we welcome whatever questions you all have today.
Thank you so much. And we love the representation of occupational therapy. And I'm quoting Caitlin Sinovac, who is listening to your presentation. I'd love you to share some of the other things that you are doing with homeless and with COVID. What impact has that had on the work that you're doing as well?
Absolutely. Thank you for that question. And hi, Caitlin. Oh gosh, well, we have done some really interesting work in this population. As I said, a lot of our research, and I made a commitment long ago when I started working in this population that I would never do any research for research's sake. I would always do everything that was done to better understand this population so that we could serve them better. And I know that sounds very silly to say, but so much of that I think happens that I really wanted to make sure that I made that point. And so we do research that is either brought about by a research question that the organization that we work with has, or by something that we have seen and witnessed in our clinic that has brought about a research question to myself and my students. And so one of the really interesting studies that we're just finishing is actually, I have 4 phenomenal students who have just blown me away and done a study, a 3-part study on the experience of individuals experiencing homelessness who menstruate and what it is like to manage a period while homeless. And that has been incredibly fascinating to see how that occupational participation has seeped in and created like occupational dysfunction in other areas of their lives. So they did focus groups with individuals who menstruate. They did focus groups with staff at shelters and service organizations. And then they did in focus groups with individuals who do not menstruate so that they could hear about the stigma that's coming from these the other parts of individuals experiencing homelessness. And what they really found was that homelessness is a very patriarchal society. And so that was incredibly fascinating to learn about. How do we then work with individuals who identify as menstruators in this population? And I say that very purposely because they included anyone who menstruated, whether that be female, gender non-binary, etc. And then I know Caitlin has done some really fascinating work on cognition in this population, and we are also looking at functional cognition in this population as well, because we're really interested in how do we then ensure that we're teaching these skills. And then Ariana, I would love if you would talk to us a little bit about your work on sleep in this population.
Yeah, so my doctoral research when I was working with Quinn, we looked at people in the St. Louis area experiencing homelessness and how they were sleeping. So we were looking at sleep deprivation as a large contributor to some of these health issues that we were seeing. And with the study that we found, 75% of them were experiencing sleep deprivation, and compared to the general population, which is around 30%. So with that, we actually had 2 other doctoral students who followed up on that research, and one is just finishing writing hers up, but she did a follow-up study providing intervention to people experiencing homelessness for sleep, so sleep hygiene intervention. Tracked it with Fitbits, and actually this was during COVID. And so she worked at the same shelter, and there's a women's night program. So there were individuals that were, because of COVID, able to sleep in their own separate area. And so that actually, there are a lot of reports that actually enabled them to sleep better because they had that individualized sleep space and it was safe, and they weren't kind of all congregated together at night, because one of the largest barriers to sleep was their environment and the noise from others and uncomfortable bedding and all that kind of stuff. And so then we had another student who also just finished her work, and she actually took the staff education route, which Quinn did talk about with this study as well, but she provided education to the staff at the shelter about the importance of sleep in this population and what we can do to try to help them sleep better and hopefully overall improve their health.
Yeah, thank you so much. I think that that's some of the really interesting occupations that very often get left behind in this population, which sort of brings me to this idea of just occupation in general. And one of the things that I mentioned in this case study was that we use the Canadian Occupational Performance Measure with Blake. And we have sort of recognized in this population that assessment is very difficult, and that there are not a lot of assessments out there that are designed for this population. So that's one of the things that we've also been working on is, and we just published a paper on a new version of the activity card sort called the Activity Card Sort Advancing Inclusive Participation. And it is designed based on the participation of the homeless population. And it also includes what we are calling non-sanctioned or the dark side of occupation, depending on if you subscribe to Dr. Kepek's or Dr. Twinley's work. And then it also includes line drawings rather than pictures, because we really wanted to be more representative of all genders, cultures, races, etc. So that was also something that we have been working on. But then specifically to COVID, I wanted to mention that we did take this sort of work that we did with Blake, and we turned it into a program called Health Management and Maintenance for the Homeless, which we delivered an 8-week program on specifically health management and maintenance with a focus on their environment. And within COVID, we had to do a lot of work on ensuring that they were understanding COVID protocols specifically. So when we did have to take a small hiatus from the shelter because they went down to just essential personnel, you know, at the beginning of COVID, sort of when we weren't sure how transmission was happening. But when we came back July 1 of 2020, we were able to do a COVID group with them. And we talked about what is COVID? And you know, we made masks together. This was like when you could make the, you know, the bandana masks, and we rolled them over with the hair ties. And this was sort of how everyone was making masks at the time before they sort of were very mainstream. And we talked about where you could get tested, what are the symptoms, things like that. And we really have had such good COVID adherence since then. And we really are recognizing that when we teach these skills with specific emphasis on the context of homelessness, we are seeing better outcomes. So another example, this is not specific to COVID, but is nutrition. We're so used to, as OTs, teaching health and nutrition as let's go eat healthy fruits and vegetables, and that's just not a possibility in this population. And so instead of that, instead of teaching go get healthy fruits and vegetables, one of the health management and maintenance group sessions is actually about, you have these 5 canned goods, a can opener, and a Tupperware container. What can you make that is the healthiest option? Or what can you buy at the McDonald's down the street that is the healthiest option? Because those are the contexts of homelessness. And that is how we have to make sure that we're meeting our clients where we're at. So I know that was sort of a long, convoluted answer to your question, but lots of interesting things happening.
No, it's so interesting. And I have to tell you, when you were describing sleep and how important it is, you know, and for the general population, maybe one of the things that have come out of COVID that helps us understand people who are homeless better and the importance of sleep is what you found in your study. Really important. And the activity card sort that
Yes.
you're describing, is that available as well? And would it be something that, you know, could replace the current activity card sort for use?
Yeah, so we are working to make it available. You're welcome to email me, and I will send it out. So that right now I'm sort of doing it by case basis. My goal is to sort of get through the next phase of testing. So we've validated it in, and I'm also happy to send the paper out to anyone who asks. We've validated it in a population experiencing homelessness. These were small samples. Population experiencing homelessness, population of staff at the shelter, and then a population of faculty and staff at a university, to demonstrate that these are occupations, the occupations that individuals experiencing homelessness participate in are not just for them. They're things that everyone participates in. These non-sanctioned occupations, or these dark side of occupations, are things that everyone does. We all just do them a little bit differently. And so what I really don't want is that dark side of occupation or non-sanctioned occupations get relegated to only marginalized populations. I don't want that to happen. I want us to recognize that in any setting that you are in, you may be seeing someone who was in a motor vehicle accident because they were engaging in substance use, or who is overworking, or who, you know, is gambling, right? Like these are all things that we all do. And so my hope is, yes, to get to a point where we can make this the more universal version of an activity card sort. But I do have a lot of work to do between now and then.
No, it sounds like a wonderful project, and I'm very familiar with Beck's Dark Side of Occupation and her book. And I think that this could be very complimentary for people
There's a
who,
chapter in the book.
yeah, I know.
Okay.
Bex and I did together. She actually was on my podcast too, discussing it. So everything,
Wonderful.
we know everything in occupational therapy sort of comes together with each other,
Doesn't
right?
it? So blended.
We all get to connect with each other. But this was great. Any last thoughts before we conclude this incredibly wonderful webinar, where I hope people get a sense that a case study is so rich with information to share, and that at work we welcome people submitting case studies.
I think that's so wonderful, and I'm certainly thinking of others that we could submit. And I think my parting words to anyone listening would just be, recognize that individuals experiencing homelessness are seen in every setting, that it doesn't matter where you work, whether it be the community or in a medical model or in schools. Everyone, you know, everyone's going to run into them. And so it's really important that we understand how to work with this population and understand the unique needs of this population so that we can address their concerns.
Absolutely.
Okay, thank you so much for spending this time with us. And I want to thank our listeners as well. And this will appear on our Learn at Work YouTube channel and on our Work Journal webinar now website. And if anybody'd like to reach you, how can they reach you?
Oh, perfect. So my email address is my last name, so TYMINSKI, first initial Q, at WUSTL, which is washustl.edu.
Great. Thank you so much. And everyone, thank you again for joining us.